Patent foramen ovale has been associated with cryptogenic stroke for many, many years. And it's a particular problem because this is a cause of stroke typically in people between age 40 and 60, sometimes even younger. And it's also a challenge because 15% of the population has PFO, and only a small percentage of those people have a stroke. And in fact, that in the US is 40 to 60,000 people a year. So this is a large population, and intuitively it seems that closing the PFO would prevent recurrent stroke. And in fact, we have a history of retrospective trials that examined the rate of stroke in the year prior to PFO closure among people with cryptogenic stroke versus the rate of stroke in the year after. And in the aggregate, 15 or more trials, several meta-analyses suggested a stroke risk reduction, or recurrent stroke risk reduction, of anywhere between 45 and 75%, which seemed like a highly beneficial therapy. These were retrospective trials, and there has been controversy regarding their validity. And in fact, so much so that the neurology guidelines, for example, give a class 3 or harmful recommendation regarding PFO closure after a first cryptogenic stroke. We have finally completed 3 prospective randomized trials comparing device closure, catheter-based device closure for PFO with medical therapy. And these were all published simultaneously in the New England Journal of Medicine in mid-September. And all 3 trials have highly concordant results, with follow-up ranging from a little over 2 years to over 10 years. The stroke risk reduction in these trials, interestingly, is the same as we had seen in retrospective non-randomized trials. And by any analytic method, intention to treat or as treated or corrected for trial dropout and such, the stroke risk reductions in these 3 prospective randomized trials are in the range of 45 to actually over 95%. And this is a comparison of device closure with either oral anticoagulant or antiplatelet therapy. Now, we in guidelines usually look at 2 prospective randomized trials as a class 1 indication level of evidence A. And here we have 3 trials. This is really a remarkable evidence base and a highly robust evidence base. And I think this bears out the intuitive notion that closing a PFO should reduce the risk of recurrent stroke. So we have a highly robust evidence base. We do have FDA approval for one of the PFO closure devices. The procedure is one of the lowest risk that we perform in cardiology. And in fact, the stroke risk reductions represent a net benefit for these trials. So I hope that we see this greater understanding of the role of the therapy lead to an appropriate utilization going forward.